Hi guys, this week we're going to talk about chest tubes and central venous catheters. I apologize first off that there's not much in your textbook that talks about either one of these two topics. There are two articles, one for each topic, located in the learning module that you are required to read. Additionally, there are some YouTube videos over each of these topics that are also a requirement for your knowledge. You will be tested over information, so be sure you get as much as you can. So we're going to talk about chest tubes first. So we're going to do a little review. You have the chest wall, you have the lungs, you have your mediastinum, and we need to remember that our lungs or our respiratory cavity operates on a negative pressure system, and this is what allows our lungs to expand, and this is made possible because there's a pleural and a pleural space. So what types of patients need chest tubes? So patients who get a pneumothorax, which is an abnormal collection of either air or gas located in the pleural space. With this collection of air, there's a collapse of lung tissue, and it can be range from a small area of a lobe or to complete lung collapse of the whole lung. You can have a spontaneous pneumothorax, which you can get when there's a rupture of a bleb, and as you remember, blebs can occur in patients who have chronic respiratory disease issues such as emphysema. There can be traumatic pneumothoraxes from trauma, stabbings, or gunshots, or you can get a tension pneumothorax, which is air in the pleural space that is unable, and I meant to say unable, to escape with exhalation. You can also get pleural effusions, which is excess fluid that builds up around the lungs in the pleural space. And you can get a hemothorax, which is a collection of blood in the pleural space. So this is a little bit of pneumothorax in a picture form. You can see that there's a large pneumothorax. You can see where there's a small pneumothorax, and the treatment is you have to remove the air that is trapped, and the chest tube allows that to happen. So what are some signs and symptoms of patients with a pneumothorax? Well, they can have respiratory distress. They can have decreased or absent breath sounds on the side located where the pneumothorax is. You might see decreased or absent chest wall movement of that side of the chest where the pneumothorax occurs. They're going to have an increased heart rate and an increased respiratory rate. There'll be pain with taking a deep breath. They may be anxious and agitated. You'll see a decrease in their O2 saturation. And sometimes you'll see a tracheal deviation, cyanosis. You might hear muffled heart sounds, and they can go into cardiac arrest, especially with a large and sudden tension pneumothorax. So some signs and symptoms of pleural effusion: you'll see patients with labored breathing. They'll have paradoxal breathing. They'll have decreased chest movement because it hurts for them to breathe. They'll have distant or decreased or absent breath sounds. They will have an increase in heart rate and a temperature. They'll have pleuritic type pain or dull chest ache and perhaps a dry cough. So patients with a hemothorax, again, respiratory distress, decreased or absent breath sounds, percussion of the chest wall. You might hear dullness over the area where there's injury or the blood has accumulated. You'll see an increase in heart rate and a decrease in blood pressure, and this is from the blood loss, and this can be quite dramatic if there's a significant blood loss. And in laboratory work, you'll see changes in their CVC, such as a decreased red blood cell count, decreased H&H. You'll also notice, hopefully, that they are going to have a decreased oxygen saturation and an increased rate of respiratory rate. So pre-placement of a chest tube, we want to know what the purpose is. So what are we putting it in for? We hopefully have either a chest x-ray or perhaps sometimes a chest CT. And we want to know the size of the chest tube that they're going to put in. And we need all the equipment we're going to need to put the chest tube in. So we're going to prepare for the insertion. The patient needs a good assessment. We want an O2 sat monitor. We want to be sure that we've checked all their current labs, CVC, any thing that might affect their coagulation. We want to make sure that they have IV access. We want to offer pain meds if possible. We want to make sure that we've gathered the equipment. Often hospitals have a chest tube insertion tray, the collection drainage system, the actual chest tube, and the suction. We want to assess vital signs. We want to be sure we've done a focused respiratory and cardiac assessment. And the nurse is going to assist the physician with placement. What is the role of the RN? The RN is going to obtain the informed consent after the primary care provider, or PCP, has done the teaching. We will give the pre-medication if it's ordered. We'll make sure that all the equipment is gathered and ready. We'll do any teaching that needs to be done. We'll position the patient per the primary care provider's preference. We'll prepare the drainage collection system. We'll do that per manufacturer's instructions as well as the primary care provider's orders. And we'll do the documentation of the procedure, the drainage, how the patient tolerated the procedure, any complications, and size and location of the insertion. We'll make sure that the chest x-ray is ordered and complete. And we'll reassess our patient after chest tube insertion. So this is just one particular type. It's a basic chest tube drainage system. The chest tube drainage system returns the negative pressure to the intrapleural space, and it's used to remove abnormal accumulations in the pleural space, either air or fluids. And we will look at some specific types of chest tube collection systems, both in lecture on Thursday and in lab, so you can see the different types that are available out there. This is just another schematic of chest tube drainage collection. You'll see that there's a side where there's a connection from the patient to the drainage system, and this is where blood or fluids that are in the pleural space are drained into, and also air can be removed from. There is also a tube that is connected to wall suction, and there's a chamber for wet when we have water seal, where sterile water is placed. And we'll discuss these when each kind, because there's also a dry setup now that doesn't require water. So we will look at all of those in the classroom. So what are the parts of our collection system? So we have the collection chamber, and that's where the chest tube from the patient connects to the collection system. And this is where the drainage from the tube is going to collect, and this is where we're going to calibrate it, and it has calibrated and numbered columns. And this is where, as a nurse, we're going to manage the output of the chest tube. There's also a water seal chamber. The tip of there's a tip of a tube that's underwater, and this allows fluid or air to drain into the pleural space, to drain from the pleural space. It prevents air from re-entering the pleural space. The water is going to oscillate, which means it's going to rise with inspiration and it's going to lower with expiration. If you see excessive bubbling in this particular chamber of the collection system, that shows that you have an air leak somewhere within the chest tube system, and this is an abnormal finding. We have the suction container, and this is what provides suction. It is controlled to provide negative pressure to the chest, and the physician will order what type or number of negative pressure it wants. On average, it's -20, but we do need to follow the physician's order. This chamber is filled with water to help achieve the suction level. It's not determined by where you set the wall suction number at, but you are going to connect it to the wall suction unit, and you're going to set that unit to low to medium suction. And this is needed to keep lung tissue from being sucked into the chest tube area itself. And in this chamber, you'll see some gentle bubbling, which indicates that the suction is present. And this gentle bubbling is a normal finding. There are dry suction systems, and in those there is an absence of bubbling in the suction container. There's a knob or a dial that's used to set the prescribed suction level in the drainage system. This too is connected to the wall suction, and there's a floater valve which indicates that you're at the proper suction level. And we'll look at a dry suction unit and a wet suction unit in class on Thursday. So post-insertion assessment and management. So we're going to monitor and record the drainage. We would notify the physician if more than 100 mils in an hour or suddenly it changed to bloody drainage. We're going to mark the chest tube drainage collection area every 2 to 4 hours related to the physician order, and we are going to use a Sharpie directly on the collection container to put the date and the time. We're going to monitor the water seal for fluctuation of fluid. We're going to monitor the suction control chamber, and we're going to make sure that there's an occlusive, sterile dressing at the insertion site. And petroleum gauze is wrapped around the chest tube right at the insertion site before the actual dressing is put on, and this is to assist in the prevention of an air leak. We're going to assess the respiratory system. We're going to listen to lung sounds, and we're going to look at the quality of the patient's respiration. We're going to keep drainage system below the level of the chest. We don't want any kinks or dependent loops in the system. We want to make sure that all connections are secure and that they're taped. We're going to encourage the patient to turn, cough, and deep breathe and use their incentive spirometer. We do not want to strip or milk the chest tubes unless there is a physician order to do so, and then you would refer to the facility's policy on this particular thing. We don't clamp the chest tube without an order or hospital policy review of clamping in your facility. Are there complications? There can be absence of fluctuation in the water seal chamber. This can be caused by the tube being obstructed. There may be dependent loops present. The suction might not be working properly, or perhaps the lungs have re-expanded, which is the goal of having the chest tube in. We might see continuous bubbling in the water seal chamber, and this might mean that there is an air leak in the system, and with that we would notify the physician. Air leaks. If consistent bubbling in the water seal chamber, then we have an air leak. It is the most common complication with chest tubes, and some of the causes can be related to the drainage system itself, a pathophysiologic air leak in the lungs. There could be injury to the esophagus or the bronchus, or a displacement of the chest tube. So we want to make sure that all connections are tight and taped. Remember, an air leak is an expected finding of an expanded lung. Therefore, if the leak is determined to be in the lung, anticipate that the tube might stay in place to suction. So how do we assess for air leak location? So we're going to immediately occlude the chest tube drainage tubing. We're going to start at the dressing site, and we're going to work our way down systematically, kind of putting a little clamp on our way down, and we're going to look for the bubbling to stop. If the bubbling stops at the site of the dressing, then the air leak is under the dressing. We'll reinforce that dressing and notify the physician. You want to make your way down the collection tube, intermittently occluding the tubing. And then when the bubbling stops, the air leak is between where you have occluded it and the patient's chest. The collection chamber may also be the source of the air leak, and it may need to be changed. Assessment of patency. So once the chest tube is inserted and connected to the drainage tube, attach the suction chamber tubing to the wall suction. You will see gentle continuous bubbling. Tape all tubing connections between the patient and the drainage unit. This prevents inadvertent or accidental disconnection. We want to do site connections and the unit to the floor. Taping is very important, making sure it's very secure. So complications. You can have malposition of the tube, and we're going to see this on the post-insertion chest x-ray and perhaps with assessment. The tube drain may be too far out, so you might get an air leak, or you might notice the patient develops subacute air in the skin around the insertion site. This is also known as subacute emphysema. And you would feel a crunchiness around that area of the skin where there's actually air underneath the surface of the skin. The treatment generally is to remove the drain and replace it at a new site by the physician, and continue to monitor the subacute emphysema for resolution. The drain may be too far in. The patient might be having pain. It can impinge vital structures such as the thoracic aorta, and a physician will pull back, resuture the chest tube in site, and repeat the chest x-ray to verify placement. We can have an obstruction of the tube. The water column, chest drain, bottle will stop fluctuating with respiration. This could be, we might want to reposition any kinked tubes. This is where we would let the physician know, and he would order a milking out or stripping of the tube, but we can only do this again with an order and then we would refer to the facility's policy. We also could have lung collapse on x-ray, and if that occurs, the tube will need to be replaced by the physician. We can have penetration into the peritoneal cavity. This can occur if the chest tube is placed below the 6th intercostal space, and that increases the risk of penetration of the pleural cavity or the diaphragm. You can also have penetration of the liver or penetration of the colon, and these may require surgery. You might have the penetration of a lung bulba, and you might look for a continuous leak or a large volume air leak. If you had this, don't remove the drain tube. We would observe the patient, notify the physician because they may need surgical intervention if severe or does not resolve. You can have penetration of the heart or major blood vessels. This occurs in patients with enlarged heart, and it may penetrate the heart. If this occurs, the tube is generally left in place, clamped, and the patient will need to go to surgery for a thoracotomy. You can also have penetration of major blood vessels. You can have pleural sepsis. The patient would show signs of fever, drain site inflammation, purulent drainage. The physician may have the tube removed and order antibiotics. If pus accumulation occurs, sometimes they do a needle aspiration biopsy. You also may get failure of the lung to expand, and this can occur from obstruction of the tube or a persistent air leak. So removal of chest tubes is done by a physician. The nurse will assist. We'll remove the dressing. The physician generally places gauze over the dressing site, has the patient take a deep breath, Valsalva down, and the tube is removed. The chest tube should be removed during the positive pressure part within the pleural space. A dressing is applied to the area, and a chest tube is, and chest x-ray is done immediately after, and generally 24 hours after that or the next morning. So always remember this, stop. So we want to be sure we look at the site, the tube, the output, the patient, and is it patent? So remember that acronym, STOP. So now we're going to talk about, and we'll review chest tube dressing changes in lab, okay? The steps and procedure for that. So now we're going to talk about central venous catheters. So central venous catheter is inserted, we can insert it in the subclavian vein, internal jugular vein, axillary vein, or femoral vein, and the tip of it sits in the superior vena cava. Why do we put them in? Usually for IV infusions. We put it in for TPN, total parenteral nutrition, viscont medications such as chemo or vasoactive drugs, where we don't want it, perhaps it will leak into the tissues, surrounding tissues. We may need to give large volumes of fluid. We also may be giving numerous different types of fluids. You can also see it put in because we can draw blood from a CVC line. We also may want to monitor the central venous pressure. Patient may also have poor peripheral access, and we can do hemodialysis through central venous catheter. You may hear this line be called either a CVC, central venous catheter, or a CVP line, central venous pressure line. Both of them refer to the same thing. It is now more correct in the literature to call it a central venous catheter, for which you can do central venous pressures from. There are different types of central venous catheters. We have non-tunneled, we have tunneled, we have peripherally inserted or PICCs, and patients may have implantable ports. So a non-tunneled percutaneous central venous catheter, aka a central line, a physician does insert it. It's usually in the subclavian vein of the upper chest or internal jugular of the neck. It may be femoral. There can be 1 to 5 lumens. And it is not the choice for home care or ambulatory clinics. Patients will either have an implantable port or a PICC type central line if they're going to be needing it at home. So what is a PICC? It's a centrally located peripheral catheter. So it's peripherally inserted central catheter. So we generally use a brachial vein in the antecubital space, and it will be inserted up, and its tip will also rest in the superior vena cava. It can be placed at the bedside. It can be placed by a physician or a specially trained RN. An X-ray is used to verify placement, and you are able to measure CVP pressures with a PICC line. They can have 1 to 3 ports on them, and they allow the same, it would be put in for some of the same reasons as a central line. We're seeing more PICC lines put in than central lines because they're easier to insert, less invasive or complicated for the patient, and we can leave them in and patients can go home with PICC catheters. So monitoring the CVP pressure, it measures the amount of blood returning to the right atrium. It's measuring systemic circulation measurement of what we term preload. It can also be referred to as right atrial pressure. However, you are not measuring within the right atrium, you are measuring what goes into the right atrium. So you will see people call it the same. Within the literature, there are varying opinions as to whether they are actually the same, but it is measuring the amount of blood that is returning to the right atrium. It can be measured in either millimeters of mercury, which would be connected to a transducer for continuous CVP monitoring, or we can measure it in centimeters of water, which is the manometer reading, which we will discuss how to do in class, and the normal reading is 5 to 10 centimeters of water. So this, if we were going to do a measurement, these are how it looks. There's a special stopcock that has openings and open and closed areas, and so we will discuss each one of those on Thursday, how that all works. So when we're going to measure, we're going to tell the patient about the procedure. We're going to make sure that our lines are patent. We're going to make sure that the manometer itself is primed. We want to use the most distal port. We want the patient as supine as possible. And we're going to document any head elevation because we want to make sure that the nurse that follows us measures it at the same spot, and that we want to make sure we measured it at the same spot that the last nurse took it at, because we're looking at trending. And head position or position of bed can change a CVP reading. And so we're going to zero it at the phlebistotic axis, which is the fourth intercostal space, mid-axillary line, and we'll read it on end expiration. So some long-term central venous catheters, you can see that there are Hickmans, there are Groschons, and this tells you a little bit about the difference of those. Patient may have a portacath. Okay. And the picture that you see here is a picture of one is a triple lumen central line that's sitting in the superior vena cava. The B is your PICC line. It's sitting in the same spot. And this up at the top, C, is an implantable port that's been surgically implanted for a patient for long-term central venous access needs. So care of the CVC. We want to make sure we assess the site and the length, so if we can know how far it's in. There will be flushing that's required for any port that's not being used, and some facilities use heparin and some use normal saline, and you'll need to refer to your facility policy. Always use a 10 cc barrel size syringe because we want to prevent creating negative pressure within there. A dressing change for a CVC is done every 7 days per policy of your facility, and PRN, if the dressing is damaged or wet or starting to come up, we would change it before 7 days. There are caps to the tip of each lumen of the CVP, and those caps are changed every 3 days. And always, always follow the facility policy. Are there complications? Yes. During insertion, you can get dysrhythmias, because it requires a guide wire to insert it in. So sometimes that guide wire is a little longer than the actual CVP line, and you can get a little tickling of the heart and cause some dysrhythmias. Patient can get a pneumothorax, one of the things that's evaluated on the post-insertion chest x-ray, There can be an air embolism, which is an emergency, and you can have bleeding. So some complications while we're maintaining a CVC line, whether it's a CVP or a PIC or an implantable port, we're always looking for infection, dislodgement, infiltration, that's why we check for patency of the lines, and occlusion of the lines. So using a CVC, when we first have a CVC or a PIC line inserted, we don't use it until the physician orders that it can be used, and that's ordered after the chest x-ray is taken and placement is verified. Each shift, we're going to check placement. We're going to flush any unused ports. Ben will aspirate a little bit back to see if we get a little blood return, and then we'll flush. And we're going to document the site, any fluids that are running, and the patency of the line, and which ports may or may not be occluded at the moment. For medication administration, we're going to SAS, which is saline administered saline, and if your facility uses heparin, then we would add an H to that. Saline, administer saline, followed by the heparin flush. So this would be with medication administration. So what we're going to do is the last half of CC that we're going to use with that flush, we're going to clamp and try to begin to clamp it and use some positive pressure to clamp that line. So we get readings of CVPs to tell us patient volume status. So what happens if we have an increased CVP? Well, some of the causes of increased CVP can be increased intrathoracic pressure. You might see this with an intubated patient on mechanical ventilation, especially if they have PEEP, positive, and expiratory pressure added. You might see it in a patient with impaired cardiac function, such as a patient with congestive heart failure, especially right-sided heart failure. You'll see increased CVP in patients who are hypervolemic. You can see an increased CVP if there's an obstruction of the superior vena cava. Sometimes you can see an increased CVP with pulmonary artery stenosis. You will see an increased CVP with a tension pneumothorax or a pleural effusion. What may cause a decreased CVP? Causes can be hypovolemia from dehydration, hemorrhage, sometimes overuse of diuretics, vasodilation, such as patients with sepsis, and reduced intrathoracic pressure. And that's the end. So once again, I want to reiterate that you please watch all those videos that are in the learning module. Please read both of the articles, since there were probably maybe 6 to 8 pages to read in your textbook. And come ready to learn some fun stuff on Thursday. Thanks.